Morning, good afternoon, good evening, depending on where everyone is. Welcome to the second workshop on integrating sex and gender in cancer research. Why and how to advance more equitable practice. I think we'll get started. Next slide, please. Just a few housekeeping notes. There we are. Please note that part one of this session, next slide please, is being recorded. And for the second part, we're going to say goodbye to our colleagues just joining after the fact on YouTube to have a more in-depth discussion about challenges and solutions, which we decided not to record, in fact, but we'll follow the Chatham House rules. So any products, not products, but outputs of this conversation will not be attributed to any one person or their organizations. But please feel free to introduce yourself, who you are, where you're joining from in the chat function. And please do keep yourself muted, but feel free to keep your camera on as much as you like, which in fact, it's nice to see people. Thanks. Next slide, please. Just to recap, for those who weren't at the last one, that's who I am, Professor Ophira Ginsburg at Imperial College London. Next slide, please. Workshop one, that's already happened, was on the understanding why part, where we had an overview of biological and sociocultural determinants of sex and gender variability in cancer. We had some case studies illustrating impact across cancer types and research domains. And we had an excellent session on meaningful engagement of people with lived experience by Carolyn Taylor, who's also joining today for the panel discussion. Workshop number two, next slide, please. And that's where we're at today. Will be practical guidance on the study design, data collection, and analysis, integrating sex and gender in translational, clinical, actually also basic science and implementation research, population sciences, and a view from the funders, policy and funding perspectives, as you'll hear from Cancer Research UK. And then we're going to discuss challenges and strategies. So the agenda today, next slide, please, will be, first we'll have speakers, including Mathew, Tata, Morgaine, Stiles, Alison, Berner, Carinna, Hockham. I'll give a brief bio for each of them in a moment, followed by a panel discussion with speakers from both workshops. Unfortunately, Berner Özdemir can't join us today, but we do have Carolyn with us. And then the recording stops. And in the second part of the agenda, next slide, please, we will have a moderated session by my colleagues Alice Witt and Carinna Hockham. This part will not be recorded. We'll do a brainstorm that includes whiteboard, etc. And we will cover more or less 4 main domains. And we'll follow that again in small breakout group sessions as well. Basic science, clinical research, population sciences, and the whole research ecosystem that isn't otherwise covered in those domains. And we'll have a whiteboard with those categories and start to crowdsource from all of you some challenges. Then we'll get to the strategies or solutions that those of you out here might have tried and found helpful, etc. And we'll do that in breakout sessions, which will ask you to join, as you'll hear later. You can join whichever group that you like, based on the domain of interest, basic science, etc., and according to your surname, depending on, I think we'll have a lot of people, so we'll need a lot of sessions. And we'll finalize with a bit of a reportage from the group sessions. Okay, so without further ado, it's my great pleasure and honor to introduce our speakers. First, we have Mathew Tata. Matt leads the EDI in Research program at Cancer Research UK, which is a medical research charity and the large independent funder of cancer research globally. Matt has worked in funding policy and research culture following his training as a biomedical researcher in the UK and Sweden. And after Matt, everybody will do a first name basis today, is Morgaine Stiles. Morgaine is a clinical trials manager and PhD student within the Clinical Trials and Statistics Unit at the Institute of Cancer Research here in the UK. She has a particular interest in patient and public engagement, involvement in trials methods, and diversity and inclusion within clinical research. After Morgaine, we have Alison Berner, who's a clinical lecturer at Queen Mary University of London, an honorary consultant in medical oncology at St. Bartholomew's Hospital and Chelsea and Westminster Hospitals. She leads the UK Cancer and Transition Service, a world first national clinic to integrate local oncology and gender affirming care for transgender and gender diverse people in the UK. Her research centers on reducing cancer care inequalities according to sex, gender, and sexual orientation. And finally, last but definitely not least, is Carinna Hockham, here at the George Institute, a research fellow and epidemiologist whose work focuses on understanding sex and gender differences in chronic kidney disease. She's an investigator in the Medical Science, Sex and Gender Equity, or MESSAGE project here at the George Institute, and a course lead for a new short course, Integrating Sex and Gender in Health Research and Policy, the details of which will be shared later in the session. So please, the floor is yours, Matt. Thanks.
Thanks, Ophira, and thanks everyone for joining today. It's a great pleasure to be part of the organizing committee for this workshop series, and indeed just to also be privy to kind of the work that Message and yourself, Ophira, are doing. So as you've alluded to, I work for Cancer Research UK. We're a medical research charity, and I'll explain a little bit about kind of why we're motivated around operationalizing sex and gender in cancer research as a kind of a broader aim of being more inclusive in the research that we support. So I should start by saying excellence in research is really critical as we see it in helping us beat cancer for everyone, and that cutting edge research driven by our most talented people is key to helping us unlock new and better ways to prevent, diagnose, and treat cancer. And we're determined to ensure that beating cancer means beating it for everyone. But one of our greatest remaining challenges really is understanding how and why cancers affect people differently. And kind of in line with our equality, diversity, and inclusion in research strategic approach, the reasons for those differences are multifaceted and complex. They're really rooted in structural, demographic, and socioeconomic inequalities. But there's also limited understanding of the role biology plays in underpinning those disparities, and indeed how it interacts with those other drivers. So in early October last year, that's 2025, we published our refreshed strategic approach for EDI, equality, diversity, and inclusion in research, which is for us a blueprint of how we will work towards ensuring we beat cancer for everyone. So if you can see on the slide in front of you in magenta, priority 1 on the left-hand side covers our aim to transform our understanding of the role that biology plays and also its interaction with those other causes contributing to inequalities in cancer incidence and outcome. And also captures the need to enhance how we design and deliver research in an inclusive way. We need to make sure that, for example, research participants better reflect the diversity of people affected by cancer. And I think this is very much where the alignment with today's and last month's workshops comes in. The strategic approach also includes our second priority of acting as a fair funder. That's what you see in blue on the right-hand side, developing an inclusive and diverse research community. Although I won't be discussing this today in great detail, it's obviously worth noting, as probably we'll cover later in the breakout sessions, that a diverse and inclusive research community is often empowered and motivated to actually address those aims that we see in priority 1. So obviously there's overlap and feedback between them. So when we say the role of biology, we're actually referring to a really broad range of processes and mechanisms. So it very much includes intrinsic differences between people, many of which we're already born with, but it also includes differences that result from exposures or circumstances during our lifetime. So societal, social, and environmental factors that interact with and also influence our internal physiology. It's also variation in treatment of patients, how that impacts upon cancer progression. And we're really excited how data science could help knit together these different data types to understand those interactions. But we're also very mindful of the bias that already prevails in existing data sets, in algorithms, and also in analysts' decision-making. And ultimately, we know that all this work is really underpinned by interdisciplinary and teams and with diverse expertise. And so part of our efforts really about stimulating research will be about bringing those different people together. We're not starting from scratch. We've got work underway, as you can see here, in one of our Cancer Grand Challenges for looking at the data gap for people of African descent. Also, in the top right, addressing inequalities in early detection through our International Alliance for Cancer Early Detection. Developing inclusive data science methods, and also standardizing data collection, which you'll hear more about in a moment from my colleague Morgaine. We've also funded numerous grants exploring cancer inequalities and have similar research in place across our core funded infrastructure. So you heard, if you were in the first workshop, about the importance of considering sex and gender in cancer research. Just to reiterate, and if you weren't in attendance, as far as we see it, inclusive research is robust research. There should be no sort of separation between the two. It's not just a moral mission. It generates generalizable findings that are representative of all people affected by cancer. And by being inclusive, sex and gender means we can better understand, for example, mechanisms influencing cancer biology linked to things like sex chromosomes, how gender identity might equate to variable inclusion in research, and also how treatment efficacy might be affected by both sex and gender. So that's something you should listen back to for the first workshop. And I think a simple way to illustrate this really is considering how we often measure progress in cancer using things like 5-year survival rate curve. And if we're not properly considering sex and gender in cancer research, then we often aren't visualizing heterogeneity in who's benefiting from our research. And sex and gender is really ultimately relevant to all pillars of our research strategy. So this is what the schematic on the screen should show you, namely discovering how cancer develops and progresses and ultimately how we prevent, detect, and treat it. So in terms of kind of actually the accountability that we and the broader ecosystem have, first to illustrate that we as a funder and as a charity, we support a breadth of different disciplines and research contexts, all of which stand to benefit from being sex and gender inclusive. So researchers, for example, exploring basic science, typically think often around the sex of mice that they happen to be using as a model system. But we want to extend that, for example, to thinking about how we generate synthetic data that is representative of different sex and gender identities. In translational research, we want to see cancer organoids, which are when you take patient biopsies and grow them in a dish. We want to see them develop from a range of people, but we also want, for example, biomarkers to be representative. And that's something that's particularly relevant in a global push for precision prevention. And whilst also in terms of clinical research, we'd love to ensure that we're recruiting and retaining a breadth of people to trials. We also need to be sure that those trials, the way they're designed, actually considers sex and gender as variables. Ultimately, integrating sex and gender in all this research upstream is really no use if it's not ultimately implemented into clinical practice and drug development, for example, as well as other forms of translation. So on this busy slide, I want to kind of highlight that integrating sex and gender in cancer research, it requires systemic change. I know it's something that Ophira has been championing for many years now. And I've used the COM-B framework, which is typically used for behavior change, to illustrate what I think we need for a system overhaul. So to kind of run through what COM stands for, it's about having capacity, opportunity, and motivation. If you have these 3 ingredients, you can have the recipe for promoting culture and behavior change. So in terms of capacity, we need upskilling and awareness, something that Carinna is going to speak about in a moment, as well as local expertise, so people that really actually can point you in the right direction. When it comes to applying for funding and obviously operationalizing these considerations in a research proposal, we need to make sure applicants and reviewers are aware of what good looks like. And ultimately, and probably more challengingly, we need to culturally accept that time spent on robust research design is important and it's part of the research process, however difficult it might be. We also need opportunity. People need resources that could be tools and case studies to follow, also networks to guide your working, and also funds to innovate, and also to make sure that the costs, eligible costs we allow for grants, for example, aren't actually blocking what people do. And lastly, we of course need motivation, that people see it's right to change. If you're familiar with the stick and carrot paradigm, it's the idea of, to promote change is about kind of either punishment or reward. But I think actually a better way of looking at that is how we intrinsically motivate people instead of this slightly more old-fashioned approach. That said, Acquiring and renewing funding is a potential lever, alongside promoting the idea of it being good science, to discourage the idea that it's complex and impossible to do, that if you subset, for example, by sex and gender, that you have the capacity to integrate with other data sets if you don't, let's say, have a big enough sample to start with. And then, of course, if you're working with patients in the public, as I'll speak in a moment, that, of course, it's ultimately human and people-centered research. So 3 levers that I think we wield and other funders should too, in terms of operationalizing sex and gender. The first is our funding policy, or rather sex and experimental design requirements. We actually published this a while ago in 2023 before Message, who are coordinating this workshop, to develop their policy funders framework. So I think now is an opportunity to kind of reflect on where the potential enhancements and changes we can make. Certainly something that is continually in progress is ensuring the discussion of these topics and considerations at funding panels and committees in terms of study design for all different model systems and research contexts, rather than just thinking that they're relevant to only certain pockets, particularly to the preclinical basic science world. Looking forward, we want to incorporate this as part of a broader policy framework for promoting inclusive research, particularly as we focus on intersectional inclusion beyond sex and gender as 2 sort of large and important characteristics. And ultimately, this is obviously, as I hope you've inferred, at the forefront of our strategic approach, something that we are rightfully reminded at each turn by patients and the public, or people affected by cancer, as we refer to them. So patient and public involvement, or PPI, or simply involvement, is really what focuses research to what actually matters for people, not just science in an abstracted way. And if we encourage patient or people-centered research, then research teams are more likely to hear how cancer affects people and fine-tune their research accordingly. And you can see at the bottom of this slide a number of different ways that we ensure meaningful involvement, from mandatory PPI plans to people affected by cancer speaking at our events or contributing through our own involvement panels, and then through to the involvement panels that are hosted by the teams that we've funded, and also at our core funded infrastructure. And lastly, I want to mention our infrastructure as a further lever to operationalize sex and gender in research. So we fund, as you can see in that map there across the UK, a range of institutes, centers, clinical trial units, centers of excellence, experimental cancer medicine centers, and by having that kind of collaboration around any topic, gives the benefit of sort of cohesion at a local level, but also across similar infrastructure sites to innovate and cross-compare and evaluate research practices and methods. And one key example comes out of the EDI, Equality, Diversity, Inclusion Working Group for our clinical trial unit network, for a new pilot we've helped support. And I'm now going to pass over to Morgaine to discuss that particular project. So over to you, Morgaine.
Great, thank you very much. So I hope you can see my screen. I'm going to talk to you a bit about Distinct, which is a collaboration between colleagues here at ICRC TSU and also from Queen Mary University of London. And basically what we wanted to do was collect inclusivity data from our clinical trial participants. So to give you a bit of background, in order to evaluate and monitor the inclusivity of our trials, we need to collect reliable demographic data, which historically has been very limited, and there are no national standards to guide which data to collect from trial participants and indeed how to collect it. Another consideration is that we need to be able to compare trial demographics with wider population level data, whether that's disease-specific information, or in the many cases where that's not possible, we can use UK population level data as a proxy. The NHS collects only limited demographic data routinely, and there are issues with some of the data that they do collect. So for instance, sex and gender are often conflated in NHS data collection. So it's important to collect inclusivity information from participants directly, which led us to develop the Distinct question set, where we selected questions from government surveys or advice from advocacy groups to form an initial question set. We then refined this based on patient and public feedback, and we're now at the stage where we're piloting it. And while the question set was initially designed with UK cancer trials in mind, the pilot is open now to all UK non-commercial research. So the goal was for the question set to be both acceptable to our trial participants and also to be able to be mapped to national data sets. And to that end, firstly, the project team, which included 2 patient partners, identified potential questions based on protected characteristics under the UK Equality Act 2010, and also potentially underserved groups identified by the National Institute for Health and Care Research INCLUDE project, which stands for Innovations in Clinical Trial Design and Delivery for the Underserved. And overall, at this stage, we chose 18 questions. In terms of sex and gender questions, we wanted to use the census questions as a starting point where possible for ease of comparison to a large national data set. However, the ONS gender question was highly misunderstood by many people, particularly those with English as a second language, and therefore the results are no longer classed as an official statistic, so the question wasn't appropriate for inclusion. So then we looked at the LGBT Foundation If We're Not Counted, We Don't Count guidance, and Stonewall's Do Ask, Do Tell guidance. To note that neither of these are research specifics, the Stonewall guidance was designed in an HR capacity, and the LGBT Foundation guidance was developed for use in the NHS. So we, after discussion, used a combination of both at this stage, and we made some adaptations for ease of comparison to national data sets, such as, in this case, Scotland's 2022 census. Once we drafted the initial question set, we ran 4 discussion groups to gain patient and public views on it. We advertised the PPI opportunity via advocacy groups, both within and external to our organisations, and each group focused on different parts of the question set. So we had sessions on health, disability and unpaid care, education and employment, sexual orientation and gender identity, and ethnicity, language and religion. And patient advocates were asked to self-select into their preferred group to avoid tokenism. We wanted to include people of a range of ages because understanding and acceptance of language differs between generations, and because we run cancer trials while participants are generally older, we wanted to make sure that the questions were clear to people taking part in our trials whilst also being inclusive. So participants of the sexual orientation and gender identity group had contrasting views about the relevance of some of the sex and gender questions. So some people felt the questions were routine, whereas others suggested that they might be intrusive, and this highlighted the importance of clear explanation regarding why data are being collected. Prior to the discussion group, we'd made a small adjustment to the question, the wording of the question regarding sex, as we were aware that sex and gender are often conflated. And discussion groups participants were happy with this, although one participant highlighted that not everyone has access to their birth certificate, especially people from marginalised groups. We also spoke about adding an intersex option to the sex question, but it was highlighted that intersex status may not be known until later in life, so may not be registered at birth. And this, combined with the fact that there's no UK level data of incidence rate of intersexuality, led to the decision not to add this as an option at this point. However, to note, as far as we know, our group didn't include anyone with lived experience of intersexuality because it's so rare. So we're hoping that as part of the pilot stage and future research, we'll gain feedback from people with expertise in this area. Some discussion group members felt the way that the question on trans status was initially worded, so do you identify as trans, was too heavily politicised, and suggested changes to the wording of the question. And in the discussion groups, we also explored combining the gender and trans status questions, but it led to quite a few complexities, and it was unclear how people would understand it, a combined question. So we made the decision to keep the 2 separate. And patient partners also thought it was important to add a definition of trans to the question regarding trans status. And just a general note that feedback throughout the discussion groups highlighted the importance of avoiding the term other where possible, and also providing a prefer not to say option for each question. So in terms of some of the take-home messages, there's not a one-size-fits-all approach to asking demographic questions, and we need to strike a balance between the questions being acceptable to and easy to understand by trial participants, whilst also being able to be compared to population-level data sets. It's also important to clearly explain to participants why demographic data is being collected, as well as how it will be kept confidential. And it's also vital to allow participants not to disclose information if they don't want to, and to have the option to self-describe. And it's vital to recognise the importance of intersectionality. So while we're focused on sex and gender today, Distinct consists of 15 questions covering a range of protected characteristics and potentially underserved groups. So if you'd like to find out more about Distinct or to take part in the pilot, then please do get in touch. We're interested in how people adapt the question set in different settings. And also, if you'd like to collaborate with us on further work, then again, please do let us know. And it only remains to say that this has been a collaborative effort, and we'd like to thank everyone on the slide. Of course, a huge thank you goes to the patient and public contributors who took part in the discussion groups and shaped the question set, as well as our PPI team members who did a fantastic job of shaping the plan for and facilitating the discussion groups. And thank you also to CR UK, whose fundings made the pilot possible. And if you want to know more about Distinct, you can read about our recent publication by following the QR code. And I will now hand back to Matt to say a last few words.
Thanks, Morgan. Yeah, nothing much more to add. That's a superb piece of work, and I'd really encourage anyone on the call or following afterwards to consider being part of the pilot. And I've also just popped into the chat a link and an email address if you wish to be in touch with us at CR UK. If you have any ideas or suggestions, and we'd thoroughly welcome them. And yeah, I enjoy the rest of the session, and we'll pass on to the next speaker, Dr. Alison Berner.
Thank you so much. Just having a small moment with my screen sharing. And I hope you'll all be able to see that. That was a fantastic primer from Morgan in terms of data collection that brings me on to talk about how we deliver equitable cancer research for gender diverse populations. So I'm going to bring you back to the definitions that were part of the message project for which you've heard so much about. In that actually when we're talking about sex and gender, actually we're talking about a number of different variables. And we may need to consider these differently across the scope of the research that we do. And so you can see there that when we talk about sex, actually we're talking about a variety of different sex characteristics, which may play different roles throughout the cancer continuum. And similarly with gender, we may be talking about someone's identity, but we also may be talking about how they express that. And actually that might be quite different for a trans person compared to a cis person, which is how we talk about those two things with gender modality. And when we're thinking about equity and monitoring and the possibility for discrimination and the role that that might play in cancer, then perceived or presumed gender are also incredibly important. And I'm going to bring you here to some definitions because I think that people can often feel that it's quite overwhelming to consider that there are a range of identities for individuals, both in terms of gender identity, but also sexual orientation, which I won't speak about today, but which Morgan has already touched on briefly. So when I talk about gender diverse people, I'm actually saying that this is an umbrella term for a range of gender identities that may fall outside of traditional gender norms. And when I talk about someone being trans, this is someone who identifies and uses that term because their gender identity differs from the sex that they were assigned at birth, in contrast to a cisgender person who is someone for whom those things align. And a term that we use slightly less often here in the UK, but which you may see more in international research, gender non-conforming individuals referred to as gender minority. So that's just what that means if I use that term. And when I'm talking about someone being gender non-conforming, by that I mean that their gender expression falls out of what might be conventionally expected. But not everyone who is gender non-conforming may identify as trans or gender diverse. And in fact, some people of non-heterosexual sexual orientations may also describe their gender as non-conforming. So while all of this feels quite overwhelming, I think that the real key thing is to be asking people how they identify, and to really be kind of upskilling oneself with the terminology and trying to stay abreast of it and how we include people in our research day to day. And why is this so important? Well, this is a graph of gender diverse individuals in the UK in terms of population percentage, and we've already heard from Morgan why perhaps the census isn't the best data for this. And so what I've also included is the GP patient survey, which phrased its question slightly differently and actually gives a slightly higher percentage of people identifying with what we call gender incongruence, meaning there is a disconnection between their experienced gender and the sex that they were assigned at birth. And you can see that the disclosure of that is actually highest in the youngest age groups, and that's probably due to changing societal attitudes, but actually also because perhaps those in the oldest age groups still don't feel it's safe to disclose. And so whilst we're talking a lot about data collection in this webinar, actually there's a huge amount of work to be done in terms of building trust with individuals so that they feel safe to disclose that information. And this is important because trans and gender diverse people experience numerous barriers to healthcare. This is data from back in 2018 from Stonewall, with large percentages of this community feeling that they avoid visits to the GP for, say, routine cancer screenings, avoiding healthcare even when they're really unwell, and feeling that their healthcare professionals don't understand their needs. And if this is the basis that we're working from in terms of trying to improve cancer care and engage this community in research, then we have a lot of work to do. And I've shown you already that there are a variety of sex and gender characteristics, and these might all play slightly differently into someone's risk of cancer, how they engage with cancer screening and cancer care, and their eventual outcomes. And this interacts also with access to gender affirming care for trans individuals, and the discrimination and barriers to healthcare that they might experience. And I'm not going to spend a large amount of time talking about what gender affirming care looks like for trans and gender diverse people, but that might include hormones or surgeries that affect things like hormonal milieu or their anatomy, and therefore might change a predisposition to cancer or how that cancer might be treated. And so actually these factors can play a role anywhere through the cancer pathway, and we might need to think about them differently depending on what area of cancer research we're focusing on. These are some of the potential impacts of cancer for gender diverse people, and I like to put them into three buckets, so to speak. One of them is around the quality of care and their day-to-day patient experience. So I've mentioned already something around anticipated or experienced discrimination, perhaps being misgendered, and this phenomenon that we call trans broken arm syndrome, which is where a trans person arrives at a medical appointment for something entirely unrelated, and their medical problem is put down to the fact that they are trans. Trans individuals might also experience a lack of inclusive information and also systems that are not inclusive to record this information about their sex and gender characteristics, which Morgan has already touched on. There are times when we will need to adjust care for trans and gender diverse people, and therefore we'll need to take into account those adjustments when we're researching different parts of the cancer pathway. So perhaps altered screening, perhaps altered risk profiles, and of course there's a huge amount of attention at the moment on personalising risk profiling and screening at the moment, understanding when to use sex versus gender in, say, a risk calculator, or planning particular treatments like radiotherapy or cancer surgery. And if we're focusing on adjuncts to cancer care like fertility, psychosexual counselling or end-of-life care, then actually there may be particular considerations for the trans and gender diverse community with regard to those things. So what data do we have on this community at the moment? Well, we know that subpopulations of trans people in the UK have a higher prevalence of certain cancer risk factors, and that can often be linked back to minority stress. So these are coping behaviours because of a day-to-day discriminatory outlook, turning up and wondering, you know, which toilet am I going to use and am I going to be accosted? So some of these things can be linked back there, but there might be other levers that we can use to help support these communities to drive down these risk factors. We know that there are changes to cancer risk according to hormone therapies that trans people use, but often they are actually reducing risk. So prostate cancer risk is reduced for trans women, although breast cancer risk is slightly increased, but remains lower than that for cis women. And hormone therapies and surgeries reduce breast cancer risk for trans men, though it remains higher than for cis men. There have been some US studies that have shown higher proportions of certain cancer types for trans people and poorer survival from others, though that was for the trans community as a whole and wasn't disaggregated according to sex assigned at birth, and it's a proportion, not an incidence. So there's still some work to be done to really understand that data. So why do we need to know these things, and where in the cancer research kind of areas do we need to know them? And we've spoken a little bit about data collection, but actually where we're collecting this data may affect what we actually need to know. So I've shown here the different data types that we might be dealing with. We may be founding prospective cohorts or clinical trials where we can use tools like Distinct to influence how we collect the data. We might be working with existing healthcare records which have limitations in how sex and gender characteristics are collected. And we need to know for three reasons. The first is monitoring. Are we being inclusive, and is our research applicable? And Morgaine and Matt have spoken briefly about that already, because if we're not including these individuals in our research, we're not best serving them. But in some cases, there will be direct clinical relevance, both to an individual's safety on a trial, for example, but also in discussing care with them sensitively and say if they will choose to recruit to that trial. So using an unnecessarily gendered term may mean that person is not recruited. And then there might be a direct biological or social relevance to the research question that we have, and therefore, say, for example, a subgroup analysis might be appropriate. What do the guidelines say about this? Well, for 10 years now, we've had the SAGA guidelines that do say that whilst we may not always be powered to detect differences for gender diverse individuals, we as researchers need to consider the relevance of our research for those populations. And that might mean conducting those subgroup analyses even if underpowered, or describing in the way that we talk about our work their potential implications. Morgaine has also already mentioned that we have limitations in clinical data. So actually there are three fields that are in variable use across different parts of care. We have an administrative gender, which conflates sex and gender, as Morgaine has mentioned, but we can now separately in some systems record gender identity and versus sex assigned at birth, though there isn't a field for specific gender modality. So when, as I've said, whether someone is cis or trans. There are things like diagnosis codes, but those are imperfect and do err towards a pathologizing angle, but it can help us to look in clinical data as things stand. But what we don't always have are these actual individual characteristics that matter for our research questions, like information on anatomy, hormonal physiology, or perhaps childbearing potential, which might have that safety relevance. And to top it all, until recently, if you changed your administrative gender so that your GP and the health system would gender you correctly, this changed your NHS number. So some of the data that we need is unlinked. And these are things that we need to be aware of in the data that we have now, but be really pushing in terms of policy to overcome. How do we get over these things? Well, I think co-production is the best place to start. Matt has already touched on these, and these are two papers which I would point you to how to work with trans and gender diverse communities, whether you're carrying out a bespoke study for those communities or making sure your own research is inclusive. And so these point towards forming community advisory boards where these individuals can stay with you through the life of the project, have meaningful input and see that input, receive payment and authorship, depending on the level of input. And we need to be aware that as researchers and clinicians, we have an air of privilege. So it's not enough just to have someone who is trans on the researcher board, because someone who has kind of come through that system may have a very different view to someone affected by cancer who's not had research or medical training. So actually this makes co-production essential, even if you have gender diverse people within your research team. Another priority is to shift the way that we use terminology around sex and gender. This is a paper that I really like, which makes some recommendations around this, but that we have to stop the binarization of terms around sex and gender, and it provides this really nice kind of lexicon for how we can talk about these things differently, to recognize that both sex and gender are a spectrum with many different characteristics. How inclusive are we being in trials? This was a piece of work linked to the distinct work, which you've already heard about, which audited a number of trials against the NIHR Include guidelines. It found that less than half of the protocols used a gendered term in their eligibility criteria, but it was almost 50%, and those weren't necessarily gendered trials. There were lots of gendered terms in patient information sheets and in the ways that patients were referred to, which can be incredibly off-putting. And actually, case report forms very rarely collected sex and gender separately. In addition, HIV was a major exclusion criteria, particularly in the earlier trials, but even in trials conducted up until 2022, which is really important when we consider the data that we've seen earlier, that trans individuals, particularly trans women, may have a higher rate of HIV. So I would point you towards some papers in how to improve this in the trials that you're running. This is work by a dear friend, Ash Alpert, which tackles some of the barriers around not just data collection and language, but also some of the structural barriers, and provides mechanisms to address them, including ensuring things like really open inclusion criteria around hormone therapy, and actually describes how to modify your protocols directly. This paper by Andrew Asquith is also incredibly helpful, again tackling some of the barriers for trans and gender diverse people. Interestingly, it also deals with bespoke studies for trans people, where sometimes actually the inclusion criteria and exclusion criteria, individuals felt that they were not trans enough to participate in the trial, and so actually we need to think about both ends of the spectrum. And some of the facilitators that they cite are around this co-production, creation, and ensuring that research is trans-led. And for wider LGBTQ inclusion, there is also this excellent toolkit, which I've shown you a picture of there. So that's all I wanted to say, and so I will hand over to Carinna for the next talk.
Thank you, Alison. Can everyone see my slides? Lovely. Good afternoon, everyone. It's a pleasure to be here. And thank you to Matt, Morgaine, and Alison for the excellent talks, which set up my own really nicely. So now that the previous speakers, both from the first workshop and earlier today, have set the scene for why sex and gender is important to consider in cancer research, I'm now going to very much focus on the how. How can we integrate sex and gender considerations throughout the design of individual research studies? I'll mainly draw on tools and practices relevant to epidemiology, since that's my area of expertise, but I hope that many of the principles and ways of thinking will be relevant across other fields too. And just in case they aren't, I've also included some references at the end for resources that are aimed specifically at those working preclinically. Before we start, just a quick note on terminology. We've already covered definitions of sex and gender, but it's also important to be clear about the right terms to use when referring to sex or gender. So for sex, we should use terms like females, males, intersex people, or people with variations of sex characteristics, whereas for gender, terms like women, men, and transgender or non-binary people are more appropriate. And I appreciate this might sound just like semantics, but using clear terminology helps to avoid the two concepts being conflated, which Alice has mentioned, but also which many of you identified as a common issue in the last workshop. In my talk, I plan to walk through the various stages of study design, and we'll think about some of the ways that you can integrate sex and gender into your design choices. Now, this isn't meant to be a checklist that you must definitely do, but I hope it gives you a set of prompts that can help guide your design thinking. I'll spend more time on some of these stages over others, really just for the sake of time. But I want to emphasize that none of these are more or less important when it comes to thinking about sex and gender in your work. So first off, reviewing the literature. As you know, I'm sure, every study starts with a review of the existing literature, and this is partly to understand what is already known about a disease or an intervention, and partly to identify where uncertainties remain. Now, I think most of us naturally focus on the evidence or knowledge gaps, so things like conflicting findings or unanswered questions with regards to associations or specific mechanisms, for example. What I would encourage you to do is look not only at what the literature shows, but how sex and gender were handled in getting there. So this includes conceptual gaps such as unclear, inconsistent, or inappropriate definitions of sex and gender, methodological gaps such as study designs that were not designed to be able to detect potential differences, and equity gaps, including missing perspectives and experiences. I think by doing this, you'll be in a much better position to address any of these gaps or limitations in your own work. The next stage is formulating your research question, and this is, of course, foundational. The way you frame your question shapes everything that follows, and it's often the point where important sex and gender dynamics and considerations begin to surface. In epidemiology, we often use the PICO framework, so that's population, interventional exposure, comparator, outcome, and timeframe. And this is really just a framework to use as a way of being precise about what you're studying and how you're studying it. Just to go through two quick examples. In adults with advanced melanoma, does PD-1 inhibitor immunotherapy compared to standard chemotherapy improve progression-free survival over 5 years? You'll notice that in this example, neither sex nor gender features anywhere, and that's okay. I think it's really important for us to remember that not every research question has to be about sex or gender exclusively. But as you'll see, even when they're not explicit in the question, they can still influence your design choices, such as your sampling strategy and how you plan to analyse your data. And of course, if you did want to bring sex or gender to the forefront, all it takes is a small tweak to the question to achieve this, like shifting from does this treatment work to does this treatment work differently for different sexes or genders. So let's now break this PICO framework down, and we'll look at how each component creates opportunities to think about sex and gender more deliberately. Starting with the population. The first question to ask yourself is who can actually experience the condition or phenomenon that you're studying. And this is where we need to think about the underlying biology. Where possible, I would argue that I would suggest you should define your population in a sex-neutral way, so using terms like adults or people, and you should reserve using sex or gender to define your population only when they genuinely determine who is at risk. So if we take vitamin D supplementation and prostate cancer prevention as an example, you might see the term adult men used to describe the population. However, prostate biology and the mechanism of something like vitamin D supplementation relates to sex and not gender. And so a more accurate definition that uses the right terminology would be adult males aged over 50 years. However, this definition can still exclude at-risk individuals, namely transgender women who have retained their prostate. And so to avoid any unnecessary exclusion, an even more accurate and indeed inclusive definition would focus on the relevant sex characteristic. So in this instance, that's whether individuals have a prostate, and so the participant group should be defined by the presence of that organ and not by broad sex or gender labels. The second question to consider is which mechanisms or experiences you're trying to understand. Are they biological, are they social, or are they a combination of both? For the vitamin D supplementation example above, we were looking at biological mechanisms, and so using sex-based terminology made sense. However, if you were interested in healthcare access for people with prostate cancer, gender becomes relevant. In this scenario, your population might be men and gender diverse people with a confirmed diagnosis of prostate cancer. Now, of course, just as a side note, adults with a confirmed diagnosis of prostate cancer would probably be better, but I just wanted to use this as a way of making the point that gender-based terms would be more appropriate here. Next is the intervention or exposure, and here the key is to be absolutely clear about your intent. Is sex or gender the primary exposure you're studying, or might it be the case that one or both of them modify how an intervention or exposure works? If your goal is simply to compare sexes or genders directly, say comparing lung cancer prevalence between groups, that's pretty straightforward. But if you think sex or gender could modify the effect of another exposure, and this is your primary research question, then it's important to be explicit about that upfront because it has implications for downstream decisions, and we'll come back to some of these later. Next, we move on to the comparator or control group. Usually this would be either no exposure, a placebo, a different intensity or dose of a treatment, or usual or standard care. And what I think is an interesting consideration for this component of the PICO is whether your chosen control is genuinely equivalent across sex or gender groups. And I think reviewing the prior literature with a sex and gender lens will really help you to make that judgment. So for example, what is considered a standard dose of chemotherapy may not be biologically equivalent between sexes if pharmacokinetics differ by sex. And this is something that Dr. Özdemir touched upon in the last workshop. For usual care, access to and engagement with healthcare services can differ across genders due to differences in gender norms and relations, as Alison outlined in her talk. So again, the comparator may not be socially equivalent between gender groups. Now, there may not be much that you can do about this at this stage, but by being aware of it, it allows you to build this into your analysis plan, and perhaps more importantly, keep it in mind when interpreting your findings. And finally, the outcome. So here the key is to consider where the outcome you're using might manifest differently, be measured differently, or be valued differently across sex or gender groups. And in relation to that final point, this is an area where public and patient engagement is absolutely critical because it can tell you what outcomes actually matter and whether they resonate equally across the groups that you're studying. Now that we've covered kind of the formulating and the research question stage of study design, the next stage is defining your study population. And it's useful to think about this in terms of the 3 population levels that every study moves through. So that's the target population, which is the group you ultimately want your findings to generalize to, the source population, which is the population from which potential participants are actually drawn, and the study population, i.e. those who remain after applying eligibility criteria. At each layer, people will be lost for different reasons. What you need to consider is whether these losses might differ by sex or gender. And if they do, are those differences ethically and scientifically justified, or are they an unintended source of bias that you need to address? When we talk about sex and gender in health and medical research, we often hear about the need for adequate representation. And of course, that's really important. But what counts as adequate really depends on your research question, your target population, and what you already know about them. And something that I really want to emphasize is that there is no single correct sex or gender ratio for you to strive for. Instead, there are a few different approaches that you can take when deciding on the target or sex distribution, the target distribution of your study. So one option is a 50-50 split, recruiting an equal number of women and men. This can be useful when you don't know the underlying sex or gender distribution of the target population, but it has the very obvious limitation of ignoring gender diversity entirely. Another option is proportional representation, and this is where you aim to mirror the sex or gender distribution of the target population. And this is often valuable in clinical trials where you want your findings to reflect the population that will ultimately receive the intervention. The downside to this is that if there is a big sex or gender imbalance in the underlying population, you will likely end up with very small subgroups, and that of course limits the power of any subgroup analyses. The third option is intentional overrepresentation, and this is where you recruit proportionally more participants from a particular group, which is useful if your goal is to address a specific equity issue or if you want to ensure that you have enough participants for subgroup analyses. Each of these approaches are suited to different study aims and each come with its own strengths and limitations. The key, as with everything, is to be deliberate and transparent about the approach you choose and why. When it comes to your source population, as I said, this is the population from which your participants are actually drawn, and so your recruitment setting and recruitment strategies really matter. From a sex and gender perspective, we know that there are gendered patterns in terms of healthcare access, employment, safety, social roles, and digital engagement. And this means that some recruitment settings will naturally attract certain groups more than others. This may have the knock-on effect of limiting the representativeness of your study sample, or you could use it to your advantage. For example, if you're striving for proportional or overrepresentation of a certain sex or gender group. And finally, your eligibility criteria can unintentionally and unnecessarily exclude certain sexes or genders. So it's really important that you pay attention to those. And again, speaking to patient and public representatives can really help you to make sure that your criteria are well aligned to your research goals. The next stage is planning your sample size, sorry, not sample size, data collection. When it comes to this stage, it's really important to think about what you need to collect to classify your participants, and Morgaine and Alison covered this beautifully in their talks, as well as any additional sex or gender related variables that might help you to understand or explain any differences that you observe. You also need to think about how you'll collect your data. So this includes your study schedules, your study procedures, and whether these might create differential barriers to adherence or retention. You also need to think about whether your measurement tools will perform equally well across sex and gender groups. And just to reiterate an example that Professor Ginsburg shared in the first workshop, that in the diagnosis of colon cancer, flexible sigmoidoscopy has been shown to be less effective in females than in males. And so if you were to use this procedure to ascertain an outcome related to colon cancer, for example, you have the very real risk of misclassification, particularly in females. The next stage is planning your sample size, and how you approach this, surprise, surprise, depends on your research question. Specifically, whether sex or gender is your primary exposure of interest, or whether you're examining a sex or gender interaction with another intervention or exposure. The first scenario, where you're making a direct comparison between sex or gender groups, is straightforward, and so I don't plan to spend any more time on that today. Where things become more complex is when sex or gender is treated as a potential effect modifier, and this is where I'll focus on the rest of my talk. I'm emphasizing this because I found that these two very different research goals can often get conflated in high-level discussions around sample sizes in sex and gender research. You sometimes hear that you don't need to increase your sample size when you have mixed sex or mixed gender groups, and that can be true, but only if you're not interested in interaction effects. The moment your aim is to compare effects across groups, the sample size requirements and how you conduct your analyses really does change quite drastically. So let's focus on the latter scenario. When you treat sex or gender as an effect modifier, you're assessing whether the effect of a given exposure differs between groups. As a result, you're no longer estimating a single effect, you're estimating two or more subgroup-specific effects, each with its own uncertainty, and then comparing those. And so, in order to plan a sample size for this kind of comparison, you would ideally need the expected effects in each subgroup and the difference you want or expect to detect. The challenge is that we often don't have this information, and I would hope that as sex and gender informed research becomes more routine, these inputs should become more available, but right now they usually are not. There are also very real practical constraints, especially in small disease populations or when considering more than two sex or gender groups. So whilst you would ideally power for an interaction, if that is indeed your primary aim, it won't always be possible. It's not ideal, but what you can still do is be transparent in your protocol and your statistical plan about any power constraints, report effect estimates fully together with their 95% confidence intervals to break that cycle of missing inputs, and keep your study's power in mind when interpreting interaction effects. Now moving on to the analysis stage, again, I'm focusing here on the scenario where sex or gender is not the primary exposure of interest. So historically and still today, sex and gender are most often treated as confounders in epidemiological analyses. For those of you who don't know what a confounder is, this is a variable that is associated with both the exposure and the outcome and can therefore distort the relationship that we're trying to study. So to address this, researchers have traditionally adjusted for sex or gender in their analyses, which means treating them as background factors that shift the baseline, but are assumed not to change the exposure outcome relationship itself. However, this assumption doesn't always hold, and it's been increasingly recognised and indeed increasingly shown that sex and gender can act as important effect modifiers of other exposure outcome associations. Unfortunately, we won't have time today to walk through the technical details of interaction analyses, but I've included a QR code here for an excellent tutorial paper that explains how to explore these differences. Finally, the reporting phase, just a few recommendations for how to report sex and gender interaction analysis. First, it's important to always present sex or gender specific effect estimates together with their 95% confidence intervals. You can do this either in the main text or in the supplementary material, but it's really important in order for these estimates to be used in future meta-analyses. Second, present the interaction effect itself, and this is typically the ratio of the subgroup specific effects, again with its 95% confidence interval. As with all statistical analyses, don't base your conclusions solely on p-values. It's really important that you emphasize uncertainty and lean into that, especially when your study is underpowered. Also consider the clinical or public health relevance, as well as the biological or social plausibility of any observed differences, so that you don't overstate any of your findings. And finally, adhere to the sex and gender equity in research or SAGE guidelines, which I've included the QR code for here. Some common mistakes to avoid are don't infer sex or gender differences simply by comparing estimates side by side. Numerical differences alone don't account for sampling variability, and it should not be done. Second, don't interpret a statistically significant effect in one group and not in another as evidence of a true difference. The only way that you can make that assessment is through a formal interaction test. Third, avoid assuming that a non-significant interaction means that there is definitely no difference. As I alluded to earlier, most studies are not powered to be able to detect interaction effects, even if they do exist. And so instead, it's really important to be clear about the limitations of your study and to report estimates fully so that they can be included in future meta-analyses. And finally, as with all research, avoid selective reporting. Similarities are just as important to report as differences, and the same applies to sex and gender research. So just to end, and Matt covered this in his talk earlier, there is no doubt that integrating sex and gender well into research requires additional thought and can add time to your study. But doing so reduces misclassification, improves representativeness, and strengthens analyses. And if it takes longer, then I would argue that's simply the cost of doing better science. Now, before I hand back to Ophira, I wanted to mention, and Ophira's already mentioned this, but just to let you know about a new online short course that we've developed on this topic. The first iteration starts on Monday, so unfortunately it's too late to register for this round, but if you'd like to register your interest for future cohorts, please scan the QR code here. Thank you for listening, and I'll hand back over to Ophira.
Thank you so much, Carinna, and to all the speakers for really a superb roadmap for us to follow and learn from. I personally am going to watch this several times after we post it on the George Institute YouTube channel. I hope everyone found it as informative as I did. And now the chat is a little quiet. Do feel free to share if you wish who you are, what your affiliation is or interest. There's also the Q&A box. We will have about 10, maybe 15 minutes if we can pull it off for an open panel discussion with everyone you see here. That includes from the workshop number 1 and today as well, except for Berner Özdemir, who couldn't make it. Great, well done all. So I'm going to start actually with a very specific question that Phoebe asked in the chat. Let me just pull it up now so I can read it, because I think it's from Morgaine. She had said that one barrier she's heard is wanting to have some way of collecting this type of information from people who don't agree to participate. So to monitor whether some groups disproportionately are excluded, but maybe that's not possible with ethics. Is that something being considered in the project that you're running in Distinct, Morgaine?
Yeah, that's a really good question. So thank you, Phoebe. So just to first note that lots of trials do collect some, albeit not particularly detailed demographic information in screening data from hospital sites, but there are challenges with that because it relies on hospital records, and as we've already discussed, that data can be inaccurate or missing. So we would prefer to collect self-reported information in that respect. Although using the question set to collect demographic information from people declining trial participation isn't directly within the scope of distinct, the question set could potentially be used in that context if the data was collected anonymously. However, if people have decided not to take part in a trial, they may also not want to share this information, so it's a little bit of a catch-22. But as I previously said, if we're looking at who is included in our trials, we can then have an idea of who's excluded by comparing that data to, for instance, NHS incident data sets to look at characteristics of incident data and comparing if that information is available. Again, it's not perfect. So the short answer is potentially, but I don't think it would necessarily be particularly effective. And also just to note that the discussion group participants in Distinct felt really, really strongly that the question set should be given after treatment allocation to avoid any perception from people completing the question set that their responses might influence their treatment. Right. So we strongly advise people not to provide the question set prior to study entry for people in the consideration process.
Very interesting. That's really important. Thank you for that. I think in this case, I'll pivot to Carolyn now. For those of you who weren't at the first workshop, Carolyn, you can say a couple of words about yourself. And the question I'd like to ask you is, what would you advise regarding clinical research methods? Like, how can we evolve these to integrate people with lived experience in a meaningful way, which is, of course, what so much of your work is about. And that would be including trial design, endpoint selection, interpretation, everything else while maintaining rigor. Thanks.
Yeah, thank you so much, Ophira, for that. So I think there was so much talked about this, so many ways that could be from everyone's presentations today that can be inclusive. But I think it's not, I think a lot of times people think it's about adding more like narrative to trials, but it's not. It's really about improving validity of trials. And I think that that's what is so important, because if we think about, there's always these kind of barriers of traditional data sets, and thinking of it that way, the framework is a little incomplete, right? So when you really are including people, understanding the processes, and I think that's why some people are so hesitant maybe to participate, because there is this pre-designed kind of methodological framework that we want to follow. And I think it's really important because inequities that exist that aren't necessarily in the normal data sets can be incorporated in when you include people with lived experience in the trial design, in just the screening questionnaires and things like that. I think it's so important to really nuance the research.
Great. Thank you so much. And you're quite right. A lot of this has come up in all of the presentations, which is fantastic. I mean, it says that I think things are maybe slowly but surely progressing in the discourse, or at least the people we are lucky enough to have join us today. I guess a related question I'll ask you, Alison, if you could make one change, that wave a magic wand idea, but if you could make one change to ensure that the whole cancer research sort of enterprise is inclusive of trans and gender diverse people, what would that be?
I think it would go back to the questions that we ask around identity at that initial point of data collection, and so much of that important work that Morgaine has done, and the training around it, so that actually we've built the trust to ask the questions and to know how to explain why we're asking the questions. So really it's that huge education piece, which is exactly what we're doing today. But I'd really like to see that as a thread running through the whole of healthcare. Because once we have trust leads to data, and from that we can spur improvements.
Right. Thanks so much for that. Trust is it's a social determinant, and it also determines whether we can do what we're meant to do as those involved in healthcare work on the research side or otherwise. Yeah, so I'm just going to pick up on that and ask Carinna, there's a lot to consider, and others also, when you described definitions and how to be inclusive in the data gathering process. And for those of us new to the space, and I'm going to consider myself among these, right? When I trained in medical oncology, I mean, my goodness, it feels like ancient times now. But really, I mean, women were just smaller men, and it was just men or women, males or females in terms of biology. So what one key action could people take to meaningfully strengthen sex and gender sort of sensitive or responsive knowledge generation? I think that's getting a little bit of what Alison was saying and what we're all trying to get at. Carinna, what do you recommend for those of us in cancer research trying to do this well without getting overwhelmed? Thanks.
Thanks, can I say two things? So
Of
one
course.
is report fully and transparently. So be open about what the limitations of your study is, and don't shy away from that. And then if you report fully, so as I said, the sex or gender specific effects, along with their 95% confidence intervals or standard errors, whatever you want, kind of whatever measure of uncertainty you want to report. If you can report those, then at least we have some chance of using them in future meta-analyses. So whilst an individual study might be underpowered to be able to detect a difference, as we accumulate this kind of sex or gender specific data over time, at least we're in a better position to be able to use them in meta-analyses or other evidence synthesis activities. So that would be the two things. Lean into your limitations, be clear about them, and then report those estimates fully together with measures of uncertainty.
Lean into our limitations. I like that. No, but humility is so important as scientists or humans. Yeah, that's really important. I have a question for Matt, but I think I'd like first to go to the Q&A. We had an anonymous participant ask, what global resources, and this is for any of you, what global resources are available that are capturing sex and gender for population-based studies that can be utilized by researchers that might be limited in their home country? What a great question, especially now. Who would like to take a crack at that? I have some thoughts, but yeah. I'll let everybody think for a moment. Carinna, please go ahead.
One thing that comes to mind is the Global Burden of Disease study. They just, at the end of last year, they introduced a sex differences chapter as part of their visual tool online. I'll drop the link in the chat. It only covers sex differences, and there are going to be issues around sex and gender being conflated within the Global Burden of Disease study. But that it includes a lot of data, and you can stratify it by male or female. It's just a binary distinction at the moment, but it's a start.
Interesting. And I wonder if I popped the name of Dr. Shireen Haidery into the chat, so people are aware who don't know. She's a gender scholar, formerly was an HIV and cancer researcher, and now is a social scientist doing amazing work at this intersection of sex, gender, and health research. She was also our gender scholar for the Lancet Commission on Women, Power, and Cancer, and really is the founding, brains behind the SAGER guidelines. I would be really keen to know what she thinks. I don't think she was available today, but we can reach out also to talk about her work more broadly. She also works in fragile settings. NCI, when I was at the U.S. National Cancer Institute, my colleagues, I had nothing to do with this. They had produced an introduction for a book that was, I think, a first effort to at least describe the challenges from people with lived experience on sex and gender dimensions of their healthcare experience and their research, I think, globally. So multi-country, all world regions, acknowledging some of the huge challenges. And there's places where it's, I think everyone here knows it's criminal. It has been criminalized to even have same-sex relationships, et cetera, that sort of thing. Carolyn, you were nodding before. Did you want to jump in on this one or no? Okay.
Just agreeing with you.
Agreeing, yeah. And I'll turn to Matt, actually, the last but definitely not least, before we change to the second part of this whole workshop and we say goodbye to our YouTube watchers as we're going to stop recording shortly. Matt, where do we go from encouraging the use of to mandating the use of?
It's a question that we're kind of routinely posed when it comes to, well, inclusive research, but also kind of any consideration of how to make research more robust. And I guess the counter argument we find from researchers who do not want things to be mandated is sort of along the lines of, what are we mandating, how are we mandating it, and when? I guess what we're mandating, to some extent, Message has laid out some kind of general principles, but I guess knowing how those apply to every research proposal or project differs. And on that how angle, do we have any certainty, as I think is kind of being emphasized in some of the questions of the Q&A, that researchers are fully aware of those things? So that then comes on to when, that certainly it feels pretty premature to start to dictate, for example, targets, but certainly not to require evidence and some explanation as to kind of how sex and gender are incorporated into the design in some capacity. And that's something that we have in those sex and experiments design requirements. I alluded to intrinsic motivation earlier. This is the most sustainable change. It's not when people are looking in the form of grant assessment. It needs to be something that people are doing as default. I think when I came into this role, I thought large organizations could force through this sort of change, but the saying culture eats strategy for breakfast was sort of never more true. We're beholden really to the norms, values, and behaviors of people, be they submitting an application or reviewing it. And so it's going to be this constant evolution, constant nudging and prodding. But we're really very fortunate that actually kind of the school of thought has advanced a lot, as you kind of heard from people like Carinna, Morgaine, and Alison.
Great, thank you so much. And we've got a couple of more questions now, so we're going to extend the panel just a few minutes so we have a little bit of leeway. There's a question first in the chat by Ali, currently running a PPIE project. And for those of you not from the UK, people with lived experience, right? People in communities, yeah. Gathering the experiences, views, and priorities related to collecting, storing, and usage of health data from LGBTQIA+ people living with cancer. And you're describing, Ali's describing focus groups and surveys. This could come up also in the second half if you want to save your question for then. But for those of you who can read the chat, has this been adequately addressed in anyone's previous work? Or does anyone want to be included in this as a collaboration? So this is good because collaboration was what we'd hope to end on a positive note about what we can do to work together. Does anyone want to jump in on that? We can come back to it later. Alison?
Sorry, can I just add
Ali.
my specific question was about putting the outputs of these kinds of projects in queer specific spaces. So not necessarily in research and healthcare spaces, but in non-health spaces for populations of LGBTQIA+ individuals to build trust. Sorry, just wanted to.
What a great question. Thank you. No, sure. Go ahead, Alison.
I was just going to say, I think that's hugely important. I think that the work and also the placement of outputs and health education, I'm hugely interested in this, and I've explored it in some PPIE work, and I'm hugely interested in it because my own advanced fellowship around the experiences of trans people with cancer will be looking to do some of this. And I know you've popped me an email, Ali, which I will respond to because I'm very keen to collaborate. I do think that we have some fantastic particularly trans health research charities, things like Transactional, who try to do this and ensure that online spaces are flooded with high quality information. But particularly for the trans community, so much of this work is trusted kind of, I wouldn't say siloed networks because they're incredibly extensive, but they are trusted platforms that I as a cisgender person would not access. And so I work with community members to ensure that those things reach those spaces, and that because they're very private. And I think so a wider piece of this around engagement is probably thinking about how we build trust, map those networks and ensure that things reach them perhaps through community champions, so that there is kind of wide health education. But yeah, happy to talk about that offline, about what kind of other mechanisms there might be to promote health. I've got a few that we worked up in some PPIE. So yeah, would be good to, it'd be nice to hear what others are doing.
That's great, Alison. We're going to have, that's the second part of the workshop today will be about like crowdsourcing challenges and solutions effectively. So maybe this is a good time. I see that Nicola also had a question that's relevant here, and maybe for the panelists who want to type their answer there as we're making this switch now, as I'm going to say thank you so much to those of you who are joining in the future, which is a strange thing to say. Thank you very much for joining this part, which is the recorded part of Workshop 2. And we encourage people to look for future related work on the MESSAGE message website. We should pop into the chat again. Message is the work of the George Institute for Global Health, which is at Imperial College London. And there's going to be a lot more to come. So thanks very much. And we'll stop recording now. Thank you.